All right, future EMTs, get ready. We're going deep into environmental emergencies.
Hmm.
Those situations that can turn bad really fast.
Yeah, the environment can be unpredictable, right?
Exactly. From being out in the freezing cold to dealing with intense heat, we're going to cover it all. Think of this as a refresher course, like a cheat sheet for those crucial moments out in the field.
We're going beyond the textbook today. We're bringing in real-life scenarios and those aha moments that make all the difference.
We've got excerpts from your EMT training audio, those key learning objectives you absolutely need to know, and even some visual aids to help everything click.
You'll be surprised by some of the things we uncover. Like, did you know that even with all the venomous snakes in the US, deaths from bites are actually pretty rare?
That's right. We'll talk about why that is and what to do if you ever encounter a snake bite.
And get ready for a saying that might sound a bit strange at first. No one is dead unless they're warm and dead.
It's a bit of an EMT mantra, and in the world of cold emergencies, it can be a real lifesaver.
We'll also delve into lightning strikes and those situations where you might need to do something called reverse triage.
Yeah, it's not your typical approach, but when every second counts, it can make all the difference.
Absolutely.
Okay, let's start with those cold emergencies. First things first, we need to get the terminology down.
Right, the basics.
So hypothermia, it's that sneaky threat that can creep up even when it's not super cold.
Yeah, it's not always about sub-zero temperatures.
Basically, hypothermia happens when your body loses heat faster than it can make it, and it progresses in stages: mild, moderate, and severe.
It's like going down a hill getting worse and worse with each stage.
And it can happen even in relatively mild weather if someone's caught in the rain, exposed to wind, or they have certain medical conditions.
The combination of factors can really tip the scales.
Now, imagine this. You're on scene, and you think someone might have hypothermia. What's your first priority?
Always start with the ABCs: airway, breathing, and circulation. It's the foundation of emergency care.
Right. Make sure the airway is clear, check their breathing, and feel for a pulse.
But with hypothermia, there's a catch. Sometimes finding a pulse can be tough because the blood vessels constrict to try and conserve heat.
So we're talking about a really thorough pulse check,
Yeah.
maybe even a full minute in the carotid artery.
Exactly. And this is where that saying, warm and dead, comes in. It's a reminder that even a faint pulse means there's still some heart activity.
So we shouldn't give up hope just because they're cold and unresponsive.
Right. Warming them up can bring them back. Never assume someone is gone just because they're cold. Always do that thorough pulse check. You could be the difference between life and death.
It's a powerful reminder.
It is.
Along with the ABCs, we also need to check their mental status. Are they alert and talking? Do they respond when you talk to them? Or are they completely unresponsive, even to pain?
Right. We use the AVPU scale alert, verbal, pain, unresponsive, to get a sense of how serious the hypothermia might be.
And a change in mental status is a big red flag in these situations, right?
Absolutely. It can indicate how severe the cold injury is and how urgently they need treatment.
Okay, so we've got the ABCs and mental status checked. What comes next in our assessment?
We need to gather information, ask questions. How long have they been out in the cold? What were they doing before this happened? Do they have any medical conditions we should know about?
This is where OPQRST comes in.
Yeah, onset, provocation, quality, radiation, severity, and time. It helps us piece together what's going on.
And don't forget about bystanders. They can be a goldmine of information, especially if the patient is confused or can't talk clearly.
Absolutely. They might have seen what happened or know how long the person has been out in the cold.
Now let's talk about how the body loses heat. There are 5 ways: conduction, convection, evaporation, radiation, and respiration. I remember having trouble remembering all of those back in EMT class.
Yeah, that's a lot.
Any tips for keeping them straight?
I always think CCER, conduction, convection, evaporation, radiation, respiration. Like you're sharing CCERR, stay warm. It's a little silly, but it works.
I love it. So break down those heat loss mechanisms for us. How does each one contribute to someone getting too cold?
Sure. Conduction is all about direct contact, like touching a freezing metal railing or sitting on a cold rock. Heat transfers from your body to the colder object.
Makes sense. What about convection?
Convection is heat loss through moving air or water. Think wind chill. It's why a breezy day can feel way colder than the actual temperature.
And then there's evaporation, right? Like when we sweat.
Exactly. As sweat evaporates from your skin, it takes heat with it, cooling you down.
What about radiation?
Radiation is heat loss through infrared rays. Think of your body radiating heat into a cold environment, like on a cheap night.
And finally, respiration.
Right. We lose heat with every breath we exhale. That's why you can see your breath when it's cold out that warm, moist air leaving your body.
So why is it important for us as EMTs to know all of this?
Because it helps us understand how a cold emergency might develop. If we know someone's been out in the wind and rain, we can guess they're at a higher risk for hypothermia, even if it's not freezing outside.
So it helps us connect the dots and see the bigger picture.
Exactly. And it helps us decide what to do first, getting them out of the wind, taking off wet clothes, and keeping them from losing more heat.
It's all about using our knowledge to give the best possible care to our patients. Now, let's talk about those local cold injuries. Frostnip, immersion foot, and the one everyone dreads, frostbite.
Right. Different levels of cold
It's
injury.
like a spectrum of how bad things can get.
Frostnip is the first warning sign. The skin gets cold, might turn red or white, but there's no permanent damage.
It's like your body's saying, hey, pay attention, it's getting a bit too cold here. Then you've got immersion foot, also called trench foot.
Yeah, that's caused by being in cold water for a long time. You see pale, wrinkled skin and a loss of sensation in the affected area.
And then there's frostbite. That's where things get really serious.
The tissue actually freezes. The skin feels hard and waxy, and it might look white or mottled. The hard part is you can't always tell how deep the damage goes out in the field.
So let's say we get called to a scene and we think someone has frostbite. What do we do first?
The goal is to stop it from freezing more and get them to the hospital as quickly as possible.
So we're talking about taking off any wet clothing or jewelry, covering the frostbitten area with dry, sterile dressings, and being super gentle with it.
Exactly. Rough handling can make the damage worse.
And what about those situations where it might freeze again during transport? What do we do then?
That's a tough call. It really depends on the situation and your local protocols. If there's a big risk of it refreezing, it's actually better to leave it unthawed. Rewarming and then refreezing can cause even more damage.
It's a delicate balance.
It is. And talking to the hospital clearly is really important. We need to give them all the details about the injury and what happened so they're ready to take over.
Okay, let's switch gears now and talk about those really hot emergencies. Just like with cold, there's a range of severity.
From heat cramps to heat exhaustion to the most dangerous one, heat stroke.
And each one has its own signs and needs a specific approach.
Think of it like a line, with heat cramps being the mildest and heat stroke the most severe. Knowing where someone falls on that line will guide you in the field.
Okay, let's start with heat cramps. Those painful muscle spasms that often hit after intense physical activity, especially in hot weather.
Yeah, it's your muscles screaming for electrolytes.
So even though heat cramps are the mildest form of heat illness, they can still be really painful and knock you down.
And they're a warning sign that the body is struggling to stay cool.
So what do we do if we find someone with heat cramps?
Get them out of the heat, rest those muscles, and replace fluids and electrolytes. Have them drink cool water or a sports drink, and if you can, move them to a shaded or air-conditioned spot.
And a little massage on those cramping muscles can help too, right?
Yeah, it can provide some relief.
Okay, next up is heat exhaustion, which is more serious than heat cramps. It happens when you lose too much fluid and electrolytes through sweating, leading to hypovolemia.
Like, your body's cooling system is working overtime but can't keep up. With heat exhaustion, you'll see a bunch of symptoms like dizziness, weakness, nausea, headache, and even fainting.
So their body's basically saying, help, I need to cool down and get some fluids.
Exactly.
So walk us through that assessment. What are we looking for?
First, scene safety. Always. Then we get a first impression of the patient. Are they alert and responsive? Can they tell us what happened? And remember, heat can really mess with mental status. We're looking for signs of confusion, disorientation, agitation, or if they're not responding at all.
And we're still using the AVPU scale to evaluate their mental status, just like with cold emergencies, right?
Right. Then we move on to the ABCs. Is their airway clear? Are they breathing okay? What's their pulse like? If they're unresponsive and we think it's cardiac arrest, we start CPR and use the AED right away.
But in most cases of heat exhaustion, it's all about cooling them down or rehydrating them.
Exactly. We need to get them out of the heat, loosen any tight clothing, and put cool compresses on their neck, armpits, and groin.
And if they're alert and can swallow, we can encourage them to drink cool fluids, right?
Right, but never force them.
Now, what about the skin? How can we tell the difference between heat exhaustion and heat stroke?
With heat exhaustion, their skin is usually cool and clammy, which tells us they're still sweating and trying to cool down. But with heat stroke, the skin is usually hot and dry. which means the sweating mechanism has stopped working.
But sometimes people with heat stroke can still be sweating, right? Like athletes or people working in hot environments.
That's true. So we can't rely on skin assessment alone. We need to look at everything, their mental status, their vital signs, and what was going on when it happened.
And if things are really bad or aren't improving quickly, we need to get them to the hospital fast and maybe even call for ALS backup, right?
Absolutely. Heat stroke can get worse really quickly, so we need to be ready to step up the care if we need to. Now, with heat stroke, every minute counts.
It's a real emergency.
It is. We need to cool them down as fast as possible to prevent organ damage.
So we're talking about aggressive cooling measures here.
Yeah. Ideally, if we can do it safely, we'd use ice water immersion. But if that's not possible, we can spray them with cool water and fan them to increase evaporation. The goal is to bring that core body temperature down quickly.
And we're still supporting their ABCs, giving them oxygen if they need it, and keeping a close eye on their vital signs.
Of course. And with heat stroke, we need to let the hospital know early so they're ready for us when we get there.
Okay, we've covered those extreme temperatures, the freezing cold and the scorching heat. Next up, we're going to dive into those situations where water becomes the hazard.
We'll talk about drowning, diving emergencies, and how the body reacts in those underwater situations. Get ready to explore the underwater world from an EMT's point of view. So, drowning. It's often called a silent killer, and it can happen anywhere there's water.
Yeah, it's a scary thought.
It really is. And the stats back that up. Did you know that in the U.S., an average of 10 people die from unintentional drownings every single day?
Wow, 10 people every day. That's a lot more common than I thought.
Yeah, it's a serious public health issue. And it's not just about water filling the lungs. There's this reflex that happens when water enters the airway called laryngospasm.
Laryngospasm.
Yeah.
Right. Remind me what that is again.
So it's this protective thing where the muscles in the larynx, those vocal cords, they spasm and basically seal off the airway.
Like a door slamming shut.
Exactly. It's the body trying to stop water from getting into the lungs, but the problem is it also stops air from getting in.
So it's like a double-edged sword, right? Protecting the lungs, but also cutting off oxygen.
Exactly. Now, imagine you get called to a possible drowning. What's one of the first things you should think about?
Spinal injuries, especially if they were diving or jumped into the water.
Spot on. In those situations, we always assume a spinal injury and take precautions.
So let's walk through that scenario. We arrive at the scene, someone's in the water, and we suspect a spinal injury. What do we do first?
If they're still in the water, we've got to stabilize them before we try to get them out. This usually takes a few people working together.
A team effort.
Right. First, we carefully rotate their whole upper body as one unit, no twisting just the head, to get them face up.
Because twisting could make the spinal injury worse.
Exactly. So now they're face up. What's next?
We need to open the airway, right?
Right. Immediately open the airway using that jaw thrust maneuver and start ventilations, using a pocket mask if we have one.
Yeah.
And be ready for them to vomit. It happens a lot with drowning victims.
Okay, we're ventilating. How do we get them onto a backboard?
Carefully. We slide a buoyant backboard or spinal restriction device under them while we're still ventilating.
Got it.
Once it's in place, we secure their trunk and head to the board, making sure we're not moving their spine. Then we get them out of the water as a team.
And once they're out, we cover them with a blanket, assess their breathing and pulse, and give oxygen if they're breathing on their own. CPR if they're not.
Now, what about those situations where the person is submerged and we can't even see them?
That sounds like we'd need specialized training and equipment.
You're right. Those cases usually involve divers with scuba gear and special recovery techniques.
Specialized stuff.
Yeah. But even then, there's this crazy thing that can sometimes buy us some time called the diving reflex.
The diving reflex. I've heard of that. Tell me more.
So it's triggered by being submerged in cold water, and it basically slows down the body's metabolism. So they need less oxygen. It can really help, especially in kids.
Wow, like the body's hitting the pause button.
Kind of. It's not a guarantee they'll be okay, but it gives us a better chance to rescue and resuscitate them.
Okay, let's switch to diving emergencies. There are three main types, right? Air embolism, decompression sickness, and nitrogen narcosis.
You got it. Air embolism, sometimes called arterial gas embolism or AGE, is the most dangerous and the one we see most often. It happens when a diver holds their breath while coming up too quickly from a dive.
So the air in their lungs expands, but it has nowhere to go.
Right, so it forms bubbles in the bloodstream.
And those bubbles cause problems.
Big time. They block the blood vessels so oxygen can't get to vital organs. The brain and spinal cord are especially vulnerable.
What kind of symptoms would we see with an air embolism?
Oh, it can look like a lot of things. Blushy skin, frothy stuff coming out of their nose and mouth, maybe even bloody severe pain in the muscles or joints, trouble breathing, chest pain, dizziness, nausea, vomiting, confusion, even paralysis or coma.
That's a lot.
The key is to think about air embolism anytime a diver comes up with sudden symptoms that don't make sense. The faster we recognize it, the better their chances.
Okay, next is decompression sickness, also known as the bends.
Right. Decompression sickness is when bubbles, mostly nitrogen, form in the blood and tissues when a diver comes up too fast from a deep dive.
So, kind of like air embolism, but the symptoms show up later.
Exactly. Sometimes hours after the dive. That can make it tough to diagnose.
So, what are the classic signs of decompression sickness?
The big one is severe joint pain, especially in the shoulders, elbows, knees, and hips. Divers say it's this deep, aching pain. You might also see fatigue, weakness, dizziness, numbness, tingling, even paralysis, and in bad cases, neurological problems.
Sounds rough. And lastly, we have nitrogen narcosis. Is that about bubbles too?
Not quite. Nitrogen narcosis is sometimes called rapture of the deep. It's a change in consciousness that happens when a diver breathes nitrogen at high pressure, usually at depths greater than 100 feet. It's more like being drunk underwater.
So instead of blocking blood flow, the nitrogen is messing with the brain directly.
Exactly. The symptoms can be mild, like feeling lightheaded or euphoric, but they can also get serious, impaired judgment, confusion, even hallucinations.
Okay, let's talk about assessing a patient with a suspected diving emergency. What are the priorities?
Same as always. Start with scene safety and that initial assessment. But with diving emergencies, we're really focused on their breathing, circulation, and neurological status.
So listening for any signs of trouble breathing, checking for a pulse, which I imagine can be tricky, and looking for any weakness, numbness, or changes in mental status.
Right. And don't forget about possible spinal trauma, especially if there was a rapid ascent or impact. We're also using that AVPU scale to figure out how conscious they are.
Makes sense. What about airway management? Is that different with diving emergencies?
It can be. Patients often have frothy or bloody secretions in their airway, so we might need to suction. Keeping that airway clear is key. If they're not breathing well, we assist with ventilations.
What about circulation?
We're checking for a pulse in multiple locations. If we can't find one, CPR and the AED are our next steps. For conscious patients, high flow oxygen, monitor those vitals, and treat for shock if necessary.
So while we're providing supportive care, we're also gathering information about the dive itself.
Absolutely. Depth, time underwater, ascent rate, any previous diving they've done. We also want to note when the symptoms started and any relevant medical history. All of this is super important for the hospital team.
And transport decisions are crucial with diving emergencies, right? Air embolism and decompression sickness often need specialized treatment in a hyperbaric chamber.
That's right. That chamber helps to shrink those gas bubbles. We need to know where the closest one is and get the patient there ASAP.
Okay, we've covered a lot with water-related emergencies. Now let's shift gears and talk about lightning injuries. They can be pretty dramatic and often involve multiple victims.
Yeah, and triage in those situations can be different.
Different how?
Well, unlike traditional triage where we focus on the most injured patients first, lightning strikes sometimes call for reverse triage.
Reverse triage, what does that mean?
It sounds weird, but here's the thing. In a lightning strike, those who are in cardiac arrest actually have a better chance of survival than those who seem dead but still have a pulse.
So we focus on reviving those without a heartbeat first.
Exactly. The ones breathing and with a pulse are more likely to make it, while those in cardiac arrest need immediate help to get their heart going again. It's about making the best use of our resources and giving those with the best shot the fastest care.
Now, lightning strikes can cause all sorts of injuries, from burns to neurological problems. What are we looking for during the assessment?
Scene safety comes first. We have to make sure the area is safe before we get close to anyone because lightning can strike the same place twice. Then we quickly assess each patient, checking their ABCs and looking for obvious injuries.
And spinal immobilization is a must, right?
Always. That electrical current can cause powerful muscle contractions, leading to fractures and spinal injuries.
So manually stabilizing the head and neck while we open the airway with the jaw thrust? What about breathing and circulation?
If they're not breathing but have a pulse, we start bag mask ventilations with high flow oxygen. If they're in cardiac arrest, CPR and the AED are our top priorities. We also address any major bleeding and treat other injuries like fractures and burns.
And even if their injuries seem minor, we still transport for a full evaluation.
Absolutely. Lightning strikes can have delayed effects, so it's better to be safe than sorry.
Okay, we've talked about water and lightning. Now let's get into the world of bites and stings.
Time to talk about venom. We're about to explore those fascinating and sometimes scary bites and envenomations.
All right, let's talk spiders. Two main ones to watch out for in the U.S., right? The black widow and the brown recluse.
Yep, those are the big ones. The black widow has a pretty scary reputation, and for good reason.
Yeah, I wouldn't want to run into one.
They're usually black with that red hourglass shape on their abdomen, like a warning sign.
Definitely a warning sign.
Hmm.
So their venom is neurotoxic. What does that mean exactly?
Neurotoxic means it attacks the nervous system.
Yeah.
So what kind of symptoms would we see in a black widow bite?
Well, I know it's painful.
It can be. You might see localized pain and swelling, but also severe muscle cramps, abdominal pain, sweating, nausea, vomiting, and even trouble breathing.
Wow, that sounds pretty serious.
It can be. Sometimes the pain is so bad it can seem like a problem with their abdomen, so getting a good history from the patient or anyone around is really important.
So we're not just treating the bite, we're also making sure it's not something else that could be life-threatening.
Exactly. Now, for a black widow bite, we're mainly focused on supportive care. We're monitoring their ABCs, giving oxygen if they need it, and getting them to the hospital for further evaluation and possible antivenom.
Okay, what about the brown recluse? Are they as easy to spot as the black widow?
Not really. They're smaller, brown, and usually have a violin-shaped marking on their back. Their venom is cytotoxic, meaning it damages tissues. And unlike the black widow, the bite often doesn't hurt at first.
So it might be hard to know right away that they've been bitten.
Right. And that can delay treatment.
What should we look for if we think it might be a brown recluse bite?
You might just see a little red mark at first. But
Ah.
over time, it can get swollen and painful and develop that classic bullseye pattern.
Bullseye pattern. What does that look like?
Picture a target. You've got a pale center where the bite happened, then a red ring around that, and then another pale ring.
Okay, I can see that.
Mm-hmm.
And in some cases, the venom can actually cause the tissue to die.
Yeah, it can create a nasty ulcer that takes a long time to heal.
Not good. So how do we treat a brown recluse bite?
Pretty similar to a black widow bite. Clean the wound, sterile dressing, immobilize the affected limb, watch their vital signs, and get them to the hospital for further evaluation and wound care.
Okay, let's talk snakes. A lot of people are terrified of snake bites, but I've heard they're actually not that common in the U.S.
Yeah, you're right. Only about 15 deaths a year from snake bites in the whole country. But that doesn't mean we can ignore them. There are still plenty of venomous snakes out there, and their bites can be serious if not treated right.
So how can we tell if a snake bite is venomous?
Well, the classic sign is fang marks. Two little puncture wounds about half an inch apart.
Okay, fang marks, got it.
You'll probably also see some discoloration, swelling, and pain around the bite area. But not all venomous snakes leave those clear fang marks. Sometimes it can look like a non-venomous bite.
So what do we do?
When in doubt, treat it as venomous. It's always better to be safe than sorry.
Okay, good advice. Now, what about those pit vipers? I remember learning about them in EMT class. What makes them different?
Pit vipers, like rattlesnakes, copperheads, and cottonmouths, have those heat-sensing pits between their eyes and nostrils. They can actually see heat, even in the dark.
That's crazy, like built-in infrared cameras.
Right. And their venom is mainly hemotoxic, meaning it messes with the blood and tissues. Their bites can cause a lot of problems: pain, swelling, bruising, bleeding, tissue damage, nausea, vomiting, weakness, dizziness, and even shock.
So what do we do for a snake bite out in the field?
First, we need to calm the person down. Reassure them that most snake bites aren't fatal, especially if treated quickly. Keep them still and quiet to slow the spread of the venom. Then we remove any tight clothing or jewelry and gently clean the wound.
What about those old school remedies like sucking out the venom or using a tourniquet?
We don't do those anymore. They don't really work and can even cause more harm. We focus on immobilizing the limb, keeping it below heart level to reduce swelling, and getting them to the hospital as fast as we can.
What if we have the snake?
If it's safe and the snake's been killed, we can bring it with us in a secure container so the hospital can identify it and give the right antivenom if needed.
Okay, good to know. Let's move on to Hymenoptera. Stings bees, wasps, those guys.
Right. Most of those stings are just painful. Unless someone's allergic, then it can be more serious.
So what do we do for a regular sting?
If the stinger's still in there, we carefully scrape it off with a credit card or our fingernail. Don't use tweezers because squeezing can release more venom. We clean the area, put on a cold compress to help with the swelling, and maybe give them some over-the-counter pain meds.
Makes sense. But if
Yes.
they are allergic, we need to be ready for anaphylaxis.
Absolutely. Epinephrine, oxygen, maybe airway management, we have to be prepared.
All right, let's talk tick bites. I know they can carry some pretty nasty diseases like Lyme disease.
Lyme disease is no joke. It's a bacterial infection that can cause fever, headache, fatigue, muscle and joint aches, and that bullseye rash.
So what's the best way to remove a tick?
We use fine-tip tweezers to grab the tick as close to the skin as possible and pull up with steady, even pressure. No twisting or jerking that can break off parts of the tick and increase the risk of infection.
And then clean the area with antiseptic.
Exactly. And if they start showing any Lyme disease symptoms, they need to see a doctor for antibiotics. Catching it early is really important.
Okay, last but not least, marine animal injuries.
Yes, the ocean is full of creatures that can cause trouble.
That's for sure.
One of the most common is the jellyfish, or really any creature with those stinging cells called nematocysts.
Nematocysts, those are the ones that inject venom,
They
right?
got it. Getting hit by those tentacles can cause a lot of different reactions. Mild itching, severe pain, swelling, muscle cramps, even problems breathing, and shock.
Wow, that's a wide range. So how do we treat a jellyfish sting?
First, get them out of the water and carefully remove any tentacles we can see using something like a credit card or gauze, never bare hands. Then rinse the area with seawater, not fresh water.
Seawater? Why not fresh water?
Fresh water can actually make the stinging worse. It can trigger more venom release.
Interesting, so seawater it is.
Right. And for some stings, like from jellyfish and Portuguese man-of-war, hot water immersion can help. The heat breaks down the venom, reducing pain and swelling.
So hot water is good for some stings, but not all of them.
Exactly. Stings from stingrays or some venomous fish need different treatments. We might need to control bleeding, remove spines, or use hot water immersion, but it depends on what stung them.
Sounds like it's important to know the local marine life and how to treat their stings.
You got it. And always remember about tetanus and give a booster shot if they need it.
Wow, we've covered a lot today. From the cold to the heat to water emergencies to all those creatures that bite and sting. It's amazing how much there is to know about environmental emergencies.
It is, and we've only scratched the surface. But hopefully you've learned some new things, gotten some practical tips, and maybe even gained a new appreciation for how complex these situations can be.
I know I have. I feel much more prepared to handle these emergencies out in the field. It's not just about knowing what to do, but also understanding why we do it.
Exactly. Environmental emergencies can happen anytime, anywhere. By staying alert, sharpening our assessment skills, and always putting safety first, we can be the best EMTs we can be, ready for anything Mother Nature throws at us.
Great advice. Thanks for taking this deep dive with us. Keep learning, stay curious, and remember, knowledge is power, especially when it comes to saving lives.